Good afternoon, all. Welcome to our online CME for November month. And topic for today is musculoskeletal microembolization for pain relief. Chronic musculoskeletal pain is often persists despite conservative and surgical management what we are getting or patient is getting. And MSK microembolization is a innovative, minimally invasive endovascular technique which targets the abnormal neovascularization and inflammation to relieve the pain and improve the function of the conditions like tendinopathies, osteoarthritis. And to discuss the details about it, we have Dr. Mohammad Zaki, our intervention radiologist from Burjeel Medical City. He will be giving us the insight about this topic in detail. To moderate this session, we have Dr. Mohammad, our intervention radiologist and CMO from Burjeel Hospital, Abu Dhabi, and myself, Dr. Amol, and Dr. Yasir will be the panelists to coordinate this session. Over to you, Dr. Mohammad Zaki.
Okay, thank you very much, Dr. Amol, for introduction. We'll start with the background of, as you said rightly, chronic musculoskeletal pain and joint pain, tendinopathy, and in physiopathy remains not only major burden for the patient and clinician, but for the health system as well. Many patients do not respond to conservative management, whether it's a physiotherapy, injection, steroid, or other type of injection. Even I still remember as a junior, this manipulation under GA for frozen shoulder. It was really inhuman way of doing part of conservative management. There is emerging evidence that pathological neovascularization in chronically inflamed tissue plays a major role in MSK pain. As an intervention radiologist, we and Dr. Mohammed and Dr. Mustafa, we have the skill and image guided, and we have the setup to do this procedure. So what are the indication? As Dr. Mamour said, the major indication is the knee osteoarthritis. Not all the patients, we're talking about mild to moderate knee osteoarthritis, patients who are refractory to medication, injection or physiotherapy. And this patient, the group of patients who are not really ready for surgery or just poor candidate for surgery. Other condition is tendinopathy or enthesiopathy of shoulder, elbow, ankle joint, and knee. These patients were not responsive to treatment for at least 6 months. Other condition is adhesive capsulitis of the shoulder and a chronic synovitis with hypervascularity in any joint. Contraindication, on other hand, if the patient has active infection, this is a contraindication. If the patient is quite elderly, have difficult anatomy or poor vascular access, this is also a contraindication. And patients who are really immediately need surgery, which I will talk in details later on. And this slide actually explains why the microembolization works. Whereas osteoarthritis historically considered as a disease due to articular cartilage, we call it wear and tear. Now there is emerging evidence that there is actually inflammatory cascade, and there is influx of immune cell, as you see in this slide. These immune cell, what it causes, it release a mediator. These mediator not only cause pain, but also break down the cartilage matrix and worsen the changes due to osteoarthritis. And when we do the embolization, we kind of stop this cycle of changes. So basically, pathophysiology in summary is proliferation, neovascularization. There is a reparative process, thickening, pain, by selective. So what happens when you selectively block that blood supply or this neovascularization? When you cut off the blood supply, there's two things happen. One, you are reducing the inflammation by targeting these new vessels. At the same time, also you reduce this pro-inflammatory mediator, which I showed in the slide, which will release this enzyme, which is damage the cartilage. So what is microembolization? It was even new to me a few years back. So they called it now transarterial microembolization, or TAMI, or musculoskeletal embolization. It's involved a very selective. You use very small tube for our colleagues who they not aware of what we do. Very small tube go through the artery, and using the fluoroscopy room and angio room to target this inflammatory changes, the neovascular changes. We inject a microsphere, and this will block the blood supply to that area and reduce the inflammation. So, but what happened in chronic inflammation, neovascularization, then infiltration of more inflammatory cells. So we stop this cycle. It's a minimally invasive, done under local anesthesia, and a very short recovery time. So is there actually evidence for this? I mean, if you look, this is relatively new in terms of health. This is only started in 2015. Since 2015 until 2024, these are the study. And if you look, it's mostly prospective, but there is 3 I will talk about randomized clinical trial. And if you look, the follow-up varies from 12 months to 48 months. They use different types of material. Some are temporary. What I mean by temporary, there's 2 types of particles. If you can see, this is a camera, and this is actually what we use. This is a very tiny material. And there's 2 types of this. One is temporary and one is a permanent. The temporary only can last for hours to days, and the permanent stay in the vessels for longer time. So the evidence are there already. There is a systemic review which show that this is actually a safe procedure for MSK pain, and also there is pilot study. So there is 3 trial, very important trial. One done in USA by Dr. Bagla. He conclude genicular artery embolization, which is we talk about now about knee osteoarthritis. He found out in his study genicular artery embolization is better than control group. They did like sham procedure. Sham, for the people who don't know what I mean, sham. So they went inside, but they injected no particles, nothing. And the other patient who received the proper embolization. He concluded that genicular artery embolization better than the sham. There is another one done by Landers in Europe, and he found also there is a benefit. And there is one study which found there is no difference. However, in the last study, interestingly, there have been more pain relief in the patient who had microembolization. Now it's also in the NICE guidelines. In last year, NICE guidelines said this is procedure is safe and should be performed by interventional radiologist with a specific knowledge training. It is delicate. It needs somebody who knows his anatomy and knows how to deliver the medication safely. And it asks also for more research. So the takeaway from all this evidence, it's a promising procedure. It's been done in Europe, in US, and in Asia with really good outcome. So who is the ideal patient for if you have a patient with the knee osteoarthritis? What are the indication? Who's the ideal patient you would like to refer to us? So a patient who has mild to moderate osteoarthritis, that's KL score 1 to 3, who has established symptoms for at least 3 months, age more than 40, and he's refractory to at least 1 attempt of conservative management. The patient who's not suitable, who patient with arthritis due to rheumatoid or infective arthritis, patient who has a renal impairment, because we do use contrast, a patient with coagulopathy, and also exclude patient who has other reason for pain, and exclude patient with significant marrow edema, because we are worrying from bone necrosis, and also severe osteoarthritis. So osteoarthritis with really structural damage, this patient will not benefit from microembolization. So this is a diagram actually of angiogram. What you see here is a contrast in the popliteal artery and distal SFA. And these the arteries, which we call genicular artery. Some of them are above the knee joint and some of them below the knee joint. So what we do, we go and select every single one of them and inject this material, which I showed you before. It's a simple tube, very small tube. We go through the groin and then go down with the help of the X-ray machine and direct our catheter inside every single artery to interrogate this artery and inject the material to block off this new vascularization. And this is very nice case, representative case of super selective of this artery. It takes time, but you have to do it because you are targeting this area. If you look, this is the femoral artery, and this is all the different genicular artery above and below, and all this area is the neovascularization. So we're not blocking the main artery, even the branch artery. What we are blocking, we are removing this, if you like, hyperemia, the inflammatory area. So this is in the medial side, this is the lateral side, and this is again the arteries, which is the inferior arteries, before and after. It not also benefit for the patient with osteoarthritis. It also be reported to be beneficial for the patient with hemoarthrosis. I've done one patient with hemoarthrosis embolization. What embolic material we use? As I showed you, there's two types of embolic material. The temporary one is imipenem silacetin. This is the antibiotic which we use in the hospital. The idea of using this antibiotic, it's because it gets crystallization inside the artery and cause temporary blockage. This will last for a short time, do the business, block that neovascularization, and not affecting other organ nearby, which is people come to think what will happen if there is any damage. There is Nexfear, also now just available last few weeks in UAE, and Sakura is not available. There is a permanent material which already available in the market, Imposphere, Impozine, PVA, and Dipiodol. We use very small, very tiny size in order just to block the neovascularization. What's the benefit of procedure? It's minimally invasive. There is no surgery, no hospital stay. It's a day case, and it is potential alternative to unresponsive pharmacological. Doing repeated injection, patients do not respond to physiotherapy or poor compliance to the physiotherapy. Is there a risk? It's actually generally it's very safe procedure. There is still a small risk of non-target embolization or over-embolization. With the temporary material, this is not an issue because it only will last for a little while. The effectiveness may vary among individual. Depends on the patient condition and how far in the process of inflammatory change. We'd like to pick this patient as early as possible before it become more of a chronic, and I will talk about that later. A long-term outcome needs further study. What other condition we can use? Not only osteoarthritis in the knee, any problem with the tendon, because if you know the tendon, it is naturally hypovascular. And this is because of low O2 demand. And if you have vessels inside the tendon, this will cause structural weakness to the tendon. So when there's a new blood vessels come to the tendon, actually, the body tries to fight it by producing this material, which is MMP, in order to preserve the integrity. This MMP, which is naturally produced when there is inflammation, it's actually anti-angiogenic factor. So basically, we are helping the body to do what it usually does when it comes to the tendon. There is a very interesting result from plantar fasciitis. We do come across this patient often. We keep injecting them. We keep, send them for all kind of physiotherapy, and they still. We are doing one soon, inshallah. And basically, this is a retrospective study of injecting temporary embolic material in the neovascularization in the plantar fascia. So they did MRI, ultrasound, there is the thickening, there is neovascularization. Then they did this study from 2020 to 2022, 66 patients. And guess what? The result was very good, about 95% improvement in the pain score. And they concluded that ultrasound or even catheter-based embolization of the plantar fasciitis, it does work. And so there's two ways of doing it. This is the way we are doing here. It's to do ultrasound to the posterior tibial artery and 27 gauge needle. You see the needle tip inside the artery here. And then this vascularity, which is the reason for thickening and the pain, it disappears after the embolization. And if you look, the pain score, the NRS score, is maintained even after 2 to 4 years. So it really does work, this procedure, and it will be very helpful for our patient. Other way of doing it is to go through the groin. This is a plantar fasciitis. They gone through a catheter into the posterior tibial artery, and you see this blush, black blush here. This is the one which is causing the inflammatory process. And after injecting it, this is after embolization, completely disappeared. Similarly, Achilles tendons. So if we have Achilles tendinopathy, if you look at this ultrasound, before there is a thickening and there is neovascularity within the tendon. After the embolization, 2 months, thickening is less and less blood to the tendon. Again, they did direct injection. It's a day procedure. It will take 10 minutes to do, and patient will go straight home with no issues. Shoulder. This is also a very important subject. We have a lot of patients with shoulder problem. Again, they end up with repeated steroid injection, physiotherapy, and they still continue to struggle with this condition. So what they found in this paper, which published in Journal Medical Imaging in 2023, for idiopathic frozen shoulder, actually, if you look at the idiopathic frozen shoulder, there is inflammatory process, and that's why they respond well to embolization. It's highly effective. While the painful rotator cuff tear, this is occurring in younger patient. Again, there is inflammatory process to it. They do respond also to embolization. However, cuff tear arthropathy, which happens in older age group, these patients actually, they don't respond to embolization. So patient selection is very important. Adhesive capsulitis, again, any inflammatory process, it can be target. You can see from this image. So if you know adhesive, it is an idiopathic, happen in the patient between 40 and 60, 20% happen in diabetic patient. And it can be really a big issue for the patient. This is an angiogram in the axillary artery, and you can see there is hypervascularity in corresponding to MRI finding. So basically, after embolization, you don't see the blush after the embolization. Again, there is more and more cases coming. This is a case of plantar patellar tendinopathy. It's called jumper knee, and this is a chronic condition. Again, they can respond to embolization because we're targeting the inflammatory process. Even in sport injury, I come across a marathon runner who really struggled with a muscle injury despite all kind of physiotherapy and treatment. And following the embolization, he did respond and he went back to his running habit. This is a very, not recent, but this is really how far they are going with this procedure. This is a patient who has a facet joint and sacroiliac joint osteoarthritis. This is a small study, only 14 patients, but they have really about 80% success rate in 3 and 24 months. Now, this is a bit extreme, but I think the idea is the same. If there is an inflammatory process, you can target it with this procedure. So who are our target audience? Who we want to help from our colleagues? So for our orthopedic surgeon, So we would like you to refer to us patients who are not ready for surgery. And for those maybe reluctant to surgery, not fit for surgery, or sometime, like we do in the liver, we bridge them. We give them this pain relief until they become ready for surgery, or the surgery can be delayed. For our rheumatologists, Dr. Ahmed and other colleagues from other hospitals, pain with inflammatory tendinopathy or enthesiopathy who have failed conservative management. These patients are really also candidate for this. Our physiotherapy department here is a big one with the sport medicine. We can also address lateral epicondylitis, jumper knee, who are not responsive to conservative treatment, whether physiotherapy or other. Our general practitioner. So if you have a patient who has a chronic pain, joint pain, more than 3 to 6 months, and you tried conservative treatment, but still not helpful, you can offer them this. So what do you do? The referral way is that similar to we have our clinic. We will accept referral. We will see the patient in the clinic. We'll assess the patient. We'll assess the imaging, whether it's CT, MRI, what are the prior therapy, and how is the vascular anatomy. Then we will do the workup, insurance approval, and we are testing the insurance. It's a new procedure, but the cash pay is available for this procedure. Procedure is a day case. It happens in the cath lab under local sedation. It's unlikely to use any sedation, to be honest, but sometimes the patient nervous. We use very small, tiny tube in the groin, and it will last, depends on the joint, maybe 1 to 1.5 or 2 hours. Post-procedure, patient can have a little bit of what we say get worse before it get better, but we cover them with analgesia, and usually we follow them in 1, 3, and 6 months. Once we've done the procedure, the patient will go back to the physician or the referral unit or hospital. The requirement for surface is already here, whether the instrument itself, the angio room, the recovery area, IR skill available, and also we have the physiotherapy, because sometimes it can be combined. We can give them this pain relief, then go to the physiotherapy, and they have more intensive physiotherapy for their condition. And there will be a standard operating protocol on the intranet. So what's anticipated outcome for us, for the patient? It will be improved pain relief, improved function, quality of life, and potentially it will delay the surgery, reducing the need for more intensive, for more steroid injection. For referring physician, it's a new tool. You will have this new tool available here in Burjeel, so you can use it, especially for refractory MSK pain. For our Burjeel brand, we will hopefully be the center for MSK embolization, whether here or in Burjeel Hospital. And for our IR team and radiology team is an opportunity for research, publication, and also building a specialty, interventional specialty within our other interventional therapy. So referral criteria, just to summarize at the end, is a chronic MSK pain, joint or tendon, more than 6 months. There is imaging evidence of synovitis, thickening, whether in ultrasound or MRI. A clinical sign of neovascularization, this can be found on the imaging, which we will assess ourselves. Patient either not candidate for immediate surgery or seeking alternatives, just simply they don't want surgery. We don't want to lose this patient as well. And there is no active infection, and they are able to go IR procedure. A clear referral letter with the prior treatment if the patient comes from other hospital, and we will evaluate and give our opinion. So what we're going to observe, we're going to observe the conversion rate from referral to procedure. We're going to assess the success rate, that obviously will use the recommended pain, FAS, and other method. Also, we will assess the functional WOMI, OMAC for the knee, for example, and we'll also quality of life questionnaire and complication rate. And this will be available after 6 months at minimum or 1 year. So in summary, musculoskeletal microembolization is a promising technique. We are happy to launch this service here in Burjeel Holding. Successful embolization also will require support from our colleagues here in Burjeel. And let us partner together and make our Burjeel center for this procedure. And thank you very much for listening. Dr. Amul.
Yeah, thank you, Dr. Zaki. Dr. Yasir, over to you.
Thank you, Dr. Zaki, for your valid presentation. We'll give a chance to our colleague for any question or any explanation, and Dr. Muhammad Del Marzouki with us also for his contribution and comment on the Dr. Muhammad input.
Yeah, thank you, Dr. Muhammad Zaki, for the presentation. Now, maybe the question that comes to everyone before referring the case, what is the time frame for the pain relief for the patient? Because this is the most common question that we, it's come to us.
Yes. Well, it depends on the condition, and as I said, how far it is in the inflammatory process. I think for a plantar fasciitis, from my experience, it within a few days or maybe a week or so, they get really they get improvement, because it will take time for inflammatory changes to settle down. For the shoulder, I have not looked at we have not done it here, but I have not looked at but if you look in what they published here, the pain start improving and is sustained. Again, it also depends exactly when you take the patient during their disease process. I think it varies from patient to patient, to be honest.
And when is the procedure? Because this doesn't last forever, because you have to repeat. So 6 months or 1 year?
For plantar fasciitis, I think they recommended at the beginning is to do it after 3 months, and that's it. So one, and then after 3 months another, and this is what the O'Connor in his practice he does. He does once, and then after 3 months, and that's it. And the improvement will be sustained. In the shoulder, it is I don't know, it's different, because you have to go and select. Obviously, if you look at the people from Europe, they are using permanent embolic material, and they are getting better, if you like, sustained pain relief, with caveat that there's a small risk of skin ischemia when they do that, especially if they use a permanent. So it depends also what you use, Dr. Mohammed.
Thank you, Dr. Maki. So just I want to add a comment. Actually, this procedure started in 2019 or 18. And when we wanted to start the procedures long back, the problem is the referring physicians. So I want to encourage physicians who are hearing us that this procedure really does work, and it's growing very fast across the world. Intervention radiologist technique, it is very simple, mini invasive. Patients can go back home same day. The result is really magnificent when you have a pain relief where the patients they have to go for a major procedure. So we really want this procedure to be more done in Burjeel Hospital. I know we have a lot of radiologists colleague here with us. You are seeing a lot of patients who have osteoarthritis. Maybe it can be an option to be referred to the interventional radiologist, or let's say if it will create a conflict with orthopedic or referring physicians, you need to just collect those cases, refer it to us. So we will try to communicate with the referring physicians to find a way to know from where these cases is coming and to educate them. As we always try to say that we need to offer the patients more than one option, and this is one of the options that we need really to offer them.
Absolutely. I think it is complementary to the orthopedic, complementary service to the rheumatologist. There's this patient with plantar fasciitis with the knee joint who are really struggling, having injection after injection, and they are not ready for surgery. And this is the ideal patient to offer them this procedure.
Dr. Zaki, I have one question. With respect to the steroid injections and PRP injections, how we should compare microembolization with these procedures which I have mentioned, which will be more effective? And that is one question. And the durability factor as well, which will be more durable for pain-free session, pain-free comfort for the patient.
Yes, I think if you look at the pathophysiology, which I showed before, when you inject steroid, you are not treating the reason of the inflammation. You only temporary, if you like, relieve the swelling, these things. But also the steroid has a problem. In the plantar fasciitis, if you inject it in the wrong place, you will end up with a skin necrosis or even rupture. That there is, I think, one study I have looked at it at some point, which is compared the steroid injection also from Japan with this procedure, and definitely this procedure has longer effect, and also it's not as harmful to the joint as the steroid. And I think, I don't know, maybe the orthopedic colleagues, if they are here to correct me, the injection of steroids is becoming, with time, people are less keen, less to do it. There is a risk of infection. There is a risk of damaging to the cartilage as well. So I think, to be honest, I think I will find this paper, but I think it's much better than to treat the cause of the inflammation. The other thing is about durability. As I said, it depends actually. As I said, people are using temporary. They are repeating the procedure for plantar fasciitis. For the permanent or for this new next sphere or Sakura, they are doing it once. And the relief are sustainable. If you look at that, I show you this paper before, even after 2 years, they still have pain relief.
That's great to know, actually. Thank you.
The only thing is that I don't know, Dr. Zaki, if you, I mean, we need really maybe to emphasize how it's look like in the MRI and the CT scan, like, I mean, it's in the MRI. So the findings, it is very important to educate the diagnostic radiologist about the finding, because now we're talking about angiogenesis, that's mean knee with contrast. So otherwise you will, if you do a knee only without contrast, you will not see that's inflamed. Is it due to increased vascular supply? So what I would like to suggest maybe to look into the protocols that we have, and whenever we have a suspicion of a knee osteoarthritis, try to add one more sequence, or I don't know if we can just inject contrast to identify the area of hypervascularization, which based on that, identifications of the patients who really require embolization will be needed.
Yes, it's a valid point, Dr. We'll look at it. Also, we can use ultrasound because that's what they do in Japan. They use ultrasound, especially for plantar fasciitis. For the knee, I don't have the skill. I will take your point. I will look at it and we'll implement the protocol. If the patient referred to us, we'll ask to add a new contrast enhance as well.
Any question from the team, the audience? So I think there is no more question. So Dr. Amol, yeah, Dr. Yasser, please. You have a question?
Thank you, Dr. Zaki, for this presentation. Thank you, Dr. Muhammad, for your input and discussion. Thank you for all colleagues joining us in this CME. Any something you need to add, Dr. Amol?
Nothing, Dr. Yasser. Thank you so much.
Thank you.
Yeah, I would like to thank you, Dr. Amul, for bringing up interventional CME, as it is very rare. You know, we don't see there is a lot of like a focus on interventional radiology. So I want to thank you today, and we want to see more, please.
Yeah, definitely,
Inshallah.
Dr. Mohammed.
Okay.
It
Thank
is
you.
actually, we should be thanking Dr. Zaki for this. He's the one who came to me and he mentioned he want to conduct one online CME on intervention. So definitely, going forward,
Inshallah, we'll
we'll
do
conduct
more,
more
inshallah.
CMEs on intervention radiology. Yeah.
Thank you very much. Thank you.
Thank you, Doctor.
Thank you.
Okay. Thank you very much.